Hi, this is Dina Rifkin, and I'm going to tell you a little bit about one of our studies that we've done in the last couple years here at UCSD and the San Diego VA. I'm really excited about this study because it allowed us to actually use our own clinical practice to answer a really important and practical question about what it is that we share with our patients and how they understand what we tell them. So in this study, we looked at what patients understood about their end stage renal disease risk. And we looked at what their nephrologist thought of that risk. We used an online calculator to estimate their risk. And then we looked 2 years ahead. We followed those folks for 2 years to figure out what actually happened to them and how their actual outcomes compared to any of those estimates of risk that were gathered in the clinical setting 2 years prior. So we recruited 257 patients from both our clinic here at the VA in San Diego, as well as our UCSD clinics. And we simply asked the question of the patients, what do you think the likelihood is that at 2 years you'll be requiring dialysis, that you'll have end-stage kidney disease, either dialysis or a transplant? We asked the nephrologists the same question, and then we used this kidney failure risk equation to calculate the risk. Then we had to wait a while to see what really happened. But if you look at the right side of this figure, you'll see something interesting. First of all, at the bottom, you can see the real outcomes here. So there was actually a very low risk of kidney failure among people for whom the kidney failure risk equation score was low. So here we've grouped the columns by the kidney failure risk equation score. What was the percentage chance that the person was going to need dialysis or have kidney failure in the next few years? So less than 1, 1 to 5, 5 to 15, and greater than 15%. And the real outcomes matched fairly well with that. In those low categories, only 1% of the participants needed dialysis or had kidney failure in those first couple years. But that went steeply up as you got into the higher risk categories. And then what was very striking to us was that both the patients and the doctors overestimated the risk of kidney failure, particularly in those low risk situations. Both the patients and the doctors had a pretty good gradation of risk, so they knew who was at lower risk versus who was at higher risk. But they were all estimating a worse outcome, at least as far as kidney failure goes, than the risk estimator. And the risk estimator outperformed either the physicians or the patients in estimating risk. Secondarily, we also found that it was often the case that patients' estimates and their physician estimates didn't match up entirely. And so we take from the study two important findings. One, we are not necessarily doing the best job at communicating our own sense of risk to our patients, and we may not be finding out from our patients what their sense of risk is. But we're pretty good at grading it along a spectrum, so we know who's low risk and high risk. But if we want a really good estimate, this kidney failure risk equation gives us a better estimate than our own clinical judgment, which is a fairly humbling and very interesting finding that we were able to publish in the Clinical Journal of the American Society of Nephrology a few years ago.